Today, as part of our commitment to improve patients' quality of life, the Philippine Academy of Family Physicians and Sanofi welcome you to FM Talks, addressing BP lowering strategies, the obvious and essentials. Now, before we begin tonight's FM Talks, we would like to ask you to please accomplish the feedback survey on Pigeonhole Live at the end of the session. If you have a smartphone or a tablet or a laptop computer with you, just launch your internet browser and enter www.pigeonhole.at. So that's www.pigeonhole.at into the address bar. Next, key in our event passcode, which is FM Talks 0609. Once again, the event passcode is FM Talks 0609. Now, I would like to introduce you to our moderator for tonight. Our moderator is a member of the National Board of Trustees of the Philippine Academy of Family Physicians. He is also a full-time assistant professor at the Ateneo School of Medicine and Public Health. He is also the chairperson of the PAFP Committees on Informatics and Publicity and Basic Medical Education and member of the Committee on Continuing Professional Development of PAFP. He is likewise a consultant at the AMO-SUP Siemens Hospital, Manila, and is the Regional Director for Luzon of the Dementia Society of the Philippines. Doctors, let us please welcome Dr. Limuel Abrojena.
Good evening, everyone. Welcome to another edition of FM Talks. We would like to thank our partner in holding this webinar series. This evening, let me introduce to you our distinguished speaker. He is a member of the board. He is a board member of the Philippine Lipid and Atherosclerosis Society, the head of the Accreditation Committee of Special Boards and Accreditation Committee of the Philippine Heart Association, the immediate past chair of the Council of Hypertension of the Philippine Heart Association, and an active consultant at the St. Luke's Medical Center, both in Quezon City and Global City, and the Cardinal Santos Medical Center, to talk on addressing BP lowering strategies, the obvious and essentials. Please help me welcome in our virtual stage, Dr. Frederick Cheng. Good evening, sir.
Hi, good evening, Dr. Abrojena, and thank you for your kind introduction. And I would like to greet all the attendees. Pleasant evening, and I welcome you to tonight's activity. And I know despite the new norm that we are experiencing now, we do have simultaneous activities, and that's the beauty of doing a virtual. We're able to maximize our learnings wherever you are. No? So wherever you are, so hopefully we'll be able to learn something tonight. Okay, so allow me to set up my screen. Okay, so when I was thinking of what would be a good topic to discuss with you tonight, actually I suddenly came through this familiar quote, which says that what's essential is invisible to the eye. Well, all of us would know that this quote came from the popular book Little Prince. No? But what if I'm going to change it and say that it's not only what's essential, but what is dangerous may also be invisible to the eye. Hypertension has been the number one risk factor leading to target organ damage, as well as cardiovascular mortality. But I consider hypertension sort of invisible and at the same time dangerous. Why? Because our patients are asymptomatic. Unless they would routinely check their blood pressures, they would not know that their blood pressure recordings are no longer ideal. No wonder hypertension, we also call them as silent killer. Therefore, tonight, let's go through the different strategies on how we can lower blood pressure. And we will also talk about the different strategies. No? And I call this the obvious, which we know should be done, and all the different essentials in order to prevent hypertension together with its organ damage. Well, this is an unfortunate data that hypertension still ranks number one. It has not changed for the past 30 years. Hypertension, high BP, remains number one, and all the risk factors actually is almost the same. And if you would notice that all the other risk factors, if also uncontrolled, will also lead to increase in blood pressure. So therefore, I think one of the strategies in order to prevent hypertension is understanding what we call the tiered approach to cardiovascular disease prevention. This figure depicts the different levels of prevention, from primordial prevention to primary prevention and secondary and tertiary prevention. Of course, when we talk about primary prevention at the middle, okay, these are referring to how we can modify the risk factors associated with the disease development. Okay, and of course, secondary prevention, the top tier. Okay, these are patients who already have suffered from a vascular event, and we need to look for strategies in order to prevent another vascular event. But what we think would be the best would be what we call primordial prevention, which makes up the base, okay, which is to look for optimized health behaviors in order to reduce or prevent us from acquiring certain risk factors. Okay. Unfortunately, by the time our patients present at the emergency room, usually our goal is now aimed at secondary and tertiary prevention. So we hope it to be at the base and not at the apex. Now, this figure summarizes the treatment recommendations for the three most important risk factors, and that is hypertension, diabetes, and lipids. Okay. Pharmacological intervention should only be initiated in hypertension and diabetes when they reach a certain level. Let's say if the blood pressure is 140/90, if the sugar is 126 and above, that's the time you would initiate treatment. Although I would say this is in contrast to dyslipidemia, wherein the threshold in terms of initiating treatment will be based on the risk stratification. So even though you're dealing with primary prevention, if the numbers are high, then you can treat. Or if you're dealing with secondary prevention, it doesn't matter. All you need to do is start the patient on statin therapy. So therefore, to address blood pressure, first and foremost, we need to look for those patients who are hypertensive. So detection. Okay. Number two, education and trying to prevent them from developing further elevation of blood pressure and reducing the risks. And of course, number three would be finding the right strategies or management. And oftentimes, this will be a combination of all these strategies. And I think we're all aware that if we reduce our blood pressure by just 10 millimeter mercury, these are all the advantages. Okay? These are the risk reductions that you'll be able to achieve: reduction of heart disease, stroke, heart failure, as well as all-cause mortality. Okay. So secondary prevention, we mentioned earlier, has been classically defined as prevention of diseases, disease recurrence or death. Okay. So what we wanted is to make sure that they don't develop an event in the first place. That's why we call it primary prevention. Okay. So if you're able to address that, then we should have a healthy patient all throughout their life, which I know is sometimes rare. But once you reach a certain clinical threshold, that means they now develop a certain event. Okay. So what are our goals? Are we able to reverse the problem? So they're able to restore the health? Are able to maintain, the patient already has MI and all throughout they have MI. So it becomes a chronic, an old myocardial infarction. Or unfortunately, if you're not able to address them, then of course these patients will have increased morbidity and at the same time increased mortality. So in other words, we are thinking of strategies, preventive strategies in order to restore health, promote function, limit disabilities. Well, this is a comparison on how they state the different recommendations for lifestyle modification. So I think it's a bit standard. They're basically the same, whether you're citing the American College of Cardiology or the European Society of Cardiology. But the bottom line is lifestyle modification works, particularly for blood pressure. I think this is a very important slide for us to remember that whenever we tell our patients, okay, you try to lose weight, you try to avoid salt intake, you try to increase fruits and vegetables, and then you'll tell them, if you're able to reduce weight, probably you'll be able to achieve 10 to 20 millimeter mercury reduction in blood pressure. You'll be achieving additional blood pressure reduction if you do this, if you do that. Okay, so in other words, lifestyle modification, again, would be effective. So why advocate? Why recommend lifestyle modification? Well, first and foremost, because it can prevent or delay the onset of hypertension and reduce cardiovascular risk. It can prevent or delay the need for drug treatment. We try lifestyle modification first before initiating treatment. We can further improve the effects of the antihypertensive drugs that you prescribe. So there's an additive BP lowering effect. And of course, cardiovascular disease prevention. But there's one drawback. What's that drawback? Is that, well, chances are our patients will not be able to comply. Chances are there'll be poor persistence over time. So that requires a lot of patient education, follow-up, and reinforcements from us physicians. So I encountered this figure, and I think this is very timely in terms of saying how we can really manage blood pressure. Okay, so it's not just diet, it's not just exercise. We also have to address the achievement of ideal body weight. Okay, we also have to address circadian synchrony. Well, I think that's very important for our people who are or patients who are shift workers, because they have altered sleep-wake cycles. So our call center agents and so on. And I think one other aspect that I think should also be emphasized would be psychosocial stress management. Okay, and these are all the different strategies we need to make sure that all of them are in place whenever we manage blood pressure. I also would like to talk about the different physiological mechanisms why a lifestyle modification should be promoted. Well, number one, if you're able to exercise, if you're able to lose weight, eat healthy, you'll be able to decrease visceral adiposity. You'll be able to improve insulin resistance. You're able to control the sympathetic as well as the renin-angiotensin system. You're able to prevent vascular stiffening, improve on the vascular function, and reduce inflammation. Okay, and thereby reduce blood pressure. Because if you're not able to do that, then of course we know the effect, which is stiffening of the arteries leading to hypertension. Now, I decided to search whether are we able to maintain our blood pressure lifelong. I mean, that's a very interesting question. So can I maintain my blood pressure 120/80 till I reach 80 years old? Okay, but there were some areas in the world that are able to do that, and probably we can divide the world into westernized populations versus non-westernized populations. Okay, so when you say westernized, okay, chances are where these are people who spend a lot of time sitting down, okay, So chances are they have low energy expenditure. And of course, the diet would be high calories, predominantly fast food with a lot of processed meat, alcohol, sugar, refined grains, and so on. And because of added stress, their sleep-wake cycle is also interrupted and irregular. Okay. On the other hand, it's the opposite for those who are belong to the non-westernized population. Okay. So, will there be a difference in terms of their prevalence of hypertension and morbidity and mortality? Well, actually, there are certain ethnic groups, no? So actually, they called it the forager. Okay, forager. These are people who goes from one place to another searching for things, no? So that means for them to eat, no? So that means they have to travel kilometers and kilometers for them to be able to hunt. Okay, so if you look at worldwide, this is worldwide. This is the general population. As we age, you can see that the blood pressure actually, goes up. Okay, sorry. Okay, so you can see the blood pressure goes up and reaches up to 140. Okay, but for the other non-westernized population, even they reach 60 years and above, okay, across these different ethnic groups, okay, they won't reach the blood pressure of 140/90. And this is what we call their life course, wherein they're able to maintain their blood pressure. So hopefully we will be able to achieve that. Another important point that I'd like to raise is that the two important cardiovascular risk factors would be obesity and elevated blood pressure, which is hypertension. Okay, and here in this study, it showed that the life course of developing LVH, for example, would already be predicted as early as childhood. So if you have a child whose blood pressure is slightly elevated and the BMI is increased, the likelihood of that child of developing LVH would be elevated. And of course, we know the development of LVH is a strong predictor of cardiovascular events. Okay. Now, is there a relationship between exercise and blood pressure? Are there beneficial effects of exercise on BP, which is sustainable? Well, the answer to this question is that definitely yes. Although there were some meta-analysis indicated that exercise interventions may reduce blood pressure and diastolic blood pressure, let's say by about 4 millimeter mercury in the short term and medium term. And in the long run, the benefits would wane. Okay, but of course, there are beneficial effects. Question number 2 in relation to exercise and blood pressure. Can exercise lower down blood pressure even without achieving weight loss? Okay. The beneficial effects of exercise on BP seem to occur independently of body weight reduction. So we tell our patients, don't be dismayed. Even though you did not lose a significant amount of weight, by the mere fact that you increase your physical activity, then you would incur the advantages, and at the same time, lower down the blood pressure. Okay. Question number 3, what is hypertensive response to acute exercise? That's a common question raised to us also. We know that there's a physiologic increase in blood pressure when we exercise. And generally, this is not associated with adverse events. However, there's what we all refer to exaggerated hypertensive response. What's that? For example, there's an increase in systolic blood pressure during exercise by more than 60, or there's more than 50 in men. No, for women, that's approximately increase in systolic blood pressure by 50. Okay, or during exercise, your blood pressure suddenly raises to more than 190. I'm sorry, more than 210. in men and more than 190 in women. So there's a sudden steep increase in blood pressure. So that can be a prognostic marker of future development of hypertension. Let's say their blood pressure is still, let's say 130/80, but if there's an exaggerated BP response to exercise, that can be a predictor that that patient may be, there may be a high likelihood of developing hypertension in the future. Okay. Another interesting fact, this is also an interesting study, wherein the aim of this paper is whether hypertension modifies the association between level of physical activity and the degree of the LV mass, okay? And whether LVH modifies the impact of physical activity on prognosis, okay? So I think the main message here is that physical activity was associated with better prognosis. Better prognosis, despite the presence of LVH. This means that being physically active, even though you are hypertensive, okay, it will not be associated with further increase in LV mass. So I think to cut short, the message is that physical activity will be beneficial, whether you are hypertensive or not, and in fact, it can prevent you from developing further increase in LV mass indices. Okay. Now, there are many pathophysiological determinants of blood pressure. It's not because of genes alone. It is not just due to social determinants. Of course, there are studies to show that low income group, low educational status may contribute to increased prevalence of blood pressure, but likewise, environmental factors as well. Okay, so unhealthy diet, increased sodium, low potassium, physical inactivity. And oftentimes, it's a combination of all these determinants that lead to full-blown hypertension. Okay. Another concept I'd like to share is that there have been actually several studies already that demonstrated that the hypertension onset age is a highly heritable trait. Okay, so for example, if the two parents had early onset hypertension, okay, the incidence of hypertension would definitely be much, much higher. So family history, okay, more so if they develop hypertension at an early age, okay. And of course, the other end is that in the yellow line, dotted line, is that none of the hypertensive patients, none of the parents are hypertensive. So the likelihood of the child or the child of developing hypertension would now be lower. So there's a lot of a genetic and heritable component. Okay, so let's say the age of the parents. Okay, let's say they are not hypertensive; they are the reference. Okay, as compared to those parents who's at a young age, let's say at 30 years old, at 40 years old, they were already hypertensive. Okay, the odds ratio of developing cardiovascular events, of course, would be more than 2 times higher. Okay, so I think we need to also ask the strong family history of our patients, and we be able to predict that our patients may develop hypertension and future events. Okay, and another interesting point that I'd like to raise here is based on the study EPO Japan. Okay, and what they did is they measured the LTR, or the lifetime risk for coronary heart disease mortality. So this is actually a large study wherein they included more than 100,000 patients and followed them up for 15 years. Okay, so what we learned from this study is that in people who develop hypertension Okay, so from optimum, and eventually develop higher grades of hypertension at a young age. Their lifetime risk for coronary heart disease mortality would be much, much higher as compared to those who develop hypertension at a later age. So I think this paper and the results would show that young people who develop hypertension should now be adopting a healthy lifestyle and start antihypertensive therapy early on, because their lifetime risk for coronary heart disease would be very high. Okay, so that's an important concept we learned from this paper. Well, classification, that's very easy because majority of the societies actually says that 140/90 is categorized as hypertensive, except for one, which is the American Heart Association, wherein it says that 130/80 may now be classified as grade 1 hypertension, but it doesn't matter. But locally, for us, we still adopt the 140/90. So how should we achieve blood pressure control and at the same time cardiovascular protection? Okay, making sure that the blood pressure of our patients are controlled all throughout the day. So there's 24-hour blood pressure control. Okay. Number two, we want to maintain a steady BP variability. We don't want wide variations of the blood pressure, wide swinging of the blood pressure. Okay. Number three, we want to preserve the nocturnal dipping of the blood pressure. When we are asked what's the normal nocturnal dipping, the answer to that is 10 to 20%. If it's less than 10%, that's called non-dipper. If there's a more than 20% drop in blood pressure, that's considered exaggerated dipper. Okay, so the normal should be 10 to 20. So for non-dippers and exaggerated dippers, they have poorer prognosis. Okay. Another common question that is thrown to us is, which one is better? Which one is more reliable? Is it office blood pressure? Is it home blood pressure? Or is it 24-hour blood pressure monitoring? Interestingly, this paper showed that home blood pressure monitoring actually had the greatest reliability and the one that correlates best with LV mass indices. Okay, of course, there are other papers which show that 24-hour blood pressure would also give us very good predictors. Okay, and definitely the least would be office blood pressure, because the conditions, the environment is actually not conducive, so it's not reliable. So in other words, the answer to that question is either home blood pressure or 24-hour blood pressure. So what are our strategies in terms of drug treatment? Okay. Well, before we were saying, okay, start with monotherapy. And then if that's not controlled, then you try to increase the dose of the initial monotherapy. But the problem is, as you increase the dose of that one drug, you would encounter more side effects. If you try to substitute from one class to another class, you would take a lot of steps, a lot of time in order to achieve blood pressure control, because the patient has to keep on coming back. And chances are you're going to have a very low adherence rate. Okay. Monotherapy and then sequential addition of other drugs. The problem that you may face would be therapeutic inertia. Okay. So again, the patient may not come back. No? So, and that's the reason why more commonly we're now advocating combination therapy as our initial therapy. Okay. So I know you've seen this slide 1,000 times, but again, reiterating that we can start combination therapy, preferably a fixed dose combination therapy, even for first line hypertensive. If not, then you can try a 3-drug fixed dose combination and then add other drugs if the blood pressure is not controlled. Again, Okay, combination. Now, this is a fairly recent paper. This is called Hope Asian Network, wherein they analyze all the hypertension prevalence and management of our neighboring Asian countries. Okay, Philippines is number one again. Number one again in where? We use monotherapy in 86% of the time. So that means we're not following the guidelines, right? In contrast to the other neighboring countries, Asian countries, is that they use monotherapy probably in about 30-40% only. Whereas us, majority are still on monotherapy. And we know that oftentimes monotherapy, in majority of the time, will not be able to achieve target blood pressure control. Okay, so this is just to illustrate that comparing, let's say, a monotherapy of amlodipine versus a combination of irbesartan and amlodipine, well, it's a no-brainer that the combination therapy would definitely be more effective and more patients will be able to achieve blood pressure control. This is a nice slide for you to remember that there are preferred combinations. That would be RAS calcium, RAS diuretics. Okay? On the right side of the screen, of course, you also have to remember that there are drugs that we should not be combining, and that would be an ACE plus an ARB. They say that combining an RAS plus beta blocker, because they don't have good synergistic actions. So in terms of BP lowering, they're not as good. But if it's used for other indications, for example, myocardial infarction, heart failure, angina, and so on, of course, we know that RAS beta blockers work very well. But for hypertension per se, apparently RAS and beta blockers are not synergistic. We don't want to combine non-dihydropyridine, verapamil, diltiazem plus beta blocker, because you may induce more bradycardia and probably some side effects. Okay? Okay. Now, going to my last concept. What is the age of your blood vessels? Are your blood vessels aging faster than you are? Okay? So we want chronologically and our vascular age to almost be the same. Okay? And this is what we refer to as EVA. Okay? EVA actually stands for early vascular aging. Okay? So hopefully we will be able to achieve, instead of EVA, supernova. Okay? So what is supernova? Okay? That is super normal vascular aging. Okay? So what does that imply? It implies that, for example, if your vascular age is younger, vascular age, let's say by computation, there's a calculator based on your risk factors. If your vascular age is 6 years lower than your chronological age, then you are called supernova. Okay? And in these patients, you will have 40% lower risk of cardiovascular events. Okay? So don't be like EVA, but become supernova. Okay? So in summary, I did mention what are the obvious and the essentials. So let me go through one by one. Okay? Number one is we know that hypertension is still the number one modifiable risk factor. And that has been true for the past many decades, for the past many 30 years at least. Okay? Number two, I did emphasize that lifestyle modification is effective and is necessary because it would give you all the benefits. It will be an additional advantage even when the patients are already on drug therapies. Okay. Oh, sorry, this should be number three. No, nagkabaliktad, no? Combination therapy is needed in most of our hypertensive patients. Okay? In fact, with 2 drug combinations, they say about 2/3. That's about 66%. Okay? 3 drugs, probably in almost 90% of our hypertensive patients. Okay? And lastly, I introduced the concept of EVA and supernova. Okay, and that's the reason why that's the main gist of my presentation is remember the primordial, primary, and the secondary prevention. Okay, we have to think of all the different preventive strategies in order to prevent development of risk factors and prevent organ damage, prevent vascular event. And therefore, all these preventive strategies should be initiated early on. Okay, so we need to prevent early vascular aging and hope that we'll be able to achieve a super normal vascular aging. So with that, I'd like to thank everyone for your time and attention.